I get asked this question all the time when I talk about the technology. So, are you using cervical length? Are you using fetal measurements? What are you looking at? And the truth is that the AI looks at the entire image. So it doesn't look at just one thing, just another thing. It takes the full image. And the best way that I can describe it is if you look at any kind of a picture and you zoom in and zoom in and zoom in, soon enough you see only pixels and you see no image. However, the AI can recognize, down to a level of detail that we obviously can't see, that there are changes within that image that predict a delivery date. Um, of note that's interesting is we can see, on the back end, when you send an image, an ultrasound image, and it does a prediction, you can see a heat map of what specific parts it's using to make that particular prediction. And it's not the same for everybody. So in one area, they may be looking at the placenta and the cervical length. In another time, they may be looking at, the endometrium, the uterus, and the ovaries. So it's active precision kind of medicine, not just the standard. We look at the same thing for everybody all the time. To your question about, whether artificial intelligence or technology is going to replace physicians, I highly doubt it. This doesn't actually take the place of physician care. This is an additional tool that we have not until now have the opportunity to have something that augments what we do. It's to the same degree that, when ultrasound came around and we didn't have to rely on, a fetoscope or, manual palpations to decide where this baby was, there was this great technology that greatly augmented and impacted how we practice obstetrics, but clearly did not take the place of the physician and patient. That's an excellent question. How are we going to use it and how is this helpful? So if I can back up a little bit and look at deliveries in general, if you're going to have a complicated delivery, a preterm delivery, and any kind of delivery, you want to deliver in the best hospital possible. For preterm deliveries, it involves a level 3 NICU where there's um, help right away. There's the right neonatologists and pediatricians. Um, so that's important to make sure that you're delivering in the right place. So even if you can do nothing with the information except for knowing that you need to be closer to a tertiary care center, that already changes, how the baby gets managed after delivery, which greatly improves outcomes for the baby. So that's one, very quick and very easy thing. The clinically important, at least exciting for me, is that if you know somebody's going to deliver early, you have the opportunity to look for risk factors and other characteristics that you may be able to change, treat, or influence. And so there is the option to really extend a pregnancy because you know something about it. It's very hard to manage something you can't predict. 90% of preterm deliveries are in low-risk women. And so we're missing a whole host of options and possibilities that we could perhaps optimize on if that were the case. And lastly, uh, I want to speak to medical care deserts. In the East Coast and the West Coast, and where I am based, there are multiple tertiary care hospitals, multiple high-risk obstetricians, multiple OBGYNs that you can get taken care of. However, in many other areas, the closest hospital may be hours away, and there may be no high-risk obstetrician in the nearby area. And so that really is clinically important because it allows on your basic scan done in your routine care to determine whether you are a higher risk patient or not, and provide you with the ability to have those services moved over to you or for you to participate, whether it be in a virtual or a in-person manner, the management for what you actually need. First and foremost, this is not a diagnostic technology. It does not tell you what it is that's causing this or what it is that you should do about it. So, as within technology, you want to know that that's a limitation. And, frankly, I think that is good for the physicians because they really should be using their clinical judgment and speaking to the patient. So that's one limitation. The other limitation when you look at The data is that it was done from a single institution and subsequently validated by a second institution. So, it looks like it's generalizable to, the United States, and we actually do have international data that seems to confirm those same numbers. Well, when you're looking from the academic point of view, where is your evidence? The evidence is primarily from two U.S. Academic clinical centers, and we would very much like to be able to say, we have centers in the East and the West and the South that replicate those findings. When physician thinks about FDA clearance, the average physician is not entirely sure what that means. So generally, when you look at medical devices, and this is software used as a medical device, there are two pathways to use. One is what we call a 510 clearance, which means that there is something else already there that is similar enough to our technology that they're comparing and declaring for use. The other is something called de novo use, when the FDA says there is no comparable technology and we have nothing to base a comparison on. So you have to prove from the start what this technology is and how it works. And so we got de novo clearance, which means that from the FDA's point of view, there is no technology that's currently available that does this. There are very few designations that get, de novo clearance per year. And so we were incredibly excited to be able to show that this is a new technology in the space of obstetrics, and that the FDA clearly feels that this technology is going to advance women's health, and therefore had de novo clearance.